Hello, everyone. Welcome to the Dr. Sophia ObGyn Podcast. I'm an ObGyn practicing for over 15 years in my native New York City, and I love to help women learn about their bodies, empower them, and embrace themselves. On this podcast, we talk openly and with heart about all things affecting women, from pregnancy, menopause, periods, sexual health, fertility, and so much more. Disclaimer: this is general medical information based on my professional opinion and experience. For specific medical advice, please refer to your physician. Hello, everyone, and welcome to the Dr. Sophia ObGyn Podcast. Today, I am going to talk a little bit about one of my really favorite topics, which is delivering babies. Just, thinking about patients and the questions that I get, and some patient scenarios kind of made me realize that maybe all of you have some of these same questions or thought processes, and why not talk about it? So, as always, I am joined by my good friend and co-host, Touseef Mirza.
Bonjour. Hello, everybody. That's sort of like my French. I grew up in Canada, French Canadian. So I've been feeling French these past week or so for some reason.
Bonjour.
Oui, bonjour, madame.
Bonjour.
My accent is more Québécois than yours, which is more...
The Haitian French, I guess?
Yes, the Haitian French, the Creole French.
The Creole French.
And I am the Québécois French. So we wanted to talk about this, and it's interesting because even as we were just literally 5 minutes ago before we just started to record this, I was like, okay, so this is a delivery and this is the delivery. And Dr. Sophia is like, no. So there's definitely room for clarification in terms of the main ways to deliver a baby, of having a baby, and what happens in different situations.
For sure. So, first of all, as we think about a delivery, most people think, okay, we're having a baby and we're having a baby vaginally. And in most places, people say the normal way or the natural way. There's so many ways in which people conceptualize vaginal birth. And so I just wanted to go over that birth can be both vaginally or via C-section. And even under vaginal conditions, that there actually are a couple of different ways a woman still has a vaginal birth, but it can be assisted.
When we say vaginal birth, we're basically saying that the baby's coming out of the vagina.
Out of the vaginal canal.
Out of the vaginal canal. And that's how we've historically always delivered babies.
Yes.
Yes. And then the advent of science came along.
Yes.
And then we've had C-sections.
Yes.
Which has been around for over
hundreds of years.
Hundreds of years.
Yes.
Okay. All right. And now
I say hundreds of years, but maybe 100 years, more than 100 years. It's been around for a long time.
Mm-hmm. And now both forms are considered normal ways of giving birth.
Yes, exactly. Like I said, many people say, oh, I had the baby normally. And to be explicit about normally, that many times when people say normally, they mean vaginally. Mm-hmm. And that having a baby via C-section, though doesn't feel quote unquote normal, I get that, but it's still a mode of delivery.
So when you talk to your patients, do you say vaginal birth?
Yes.
Okay. And is that the same way that you speak to the nurses and everybody? Is there other terms, or that's basically the way we call this?
Yeah. In the medical field, if you're speaking with another healthcare provider or a medical professional, I usually use the medical terms. And then I try to clarify things even when speaking with patients, just so that they understand when we do speak in medical terms, they feel included in the conversation. Mm-hmm. So the way I would always describe it is, okay, we're expecting a vaginal delivery or a vaginal birth.
number one, do all of them understand right away what it means? Do you have to explain to them? And or do they feel comfortable even saying vaginal delivery? Because a lot of women don't even like to say the word vagina.
I know. And so this is why I bring up the point that, a lot of people say just the normal way or the natural way. And the implication there is that it's a vaginal delivery. So if I ask, if I have a patient and we're going over her history and I ask, well, have you had any deliveries? And she's like, yeah, I had 3 natural.
Oh, that's true. People also do say natural delivery.
They say, oh, I had natural birth.
Yes.
Which to me indicates they had a vaginal delivery. But in my mind, and when I write it down, I write normal vaginal delivery.
Normal vaginal delivery. Okay.
And even that, in writing normal vaginal delivery, I have to ask further questions. Did you need any help? Was there any complications or anything like that? Because even in a vaginal delivery or a vaginal birth, you can have like what we call assistance by either something called a vacuum, which is a small device that would go on the baby's head that is literally exactly what it sounds like, a vacuum, that would then help the mom deliver the baby with the healthcare provider actually while the mother's pushing, and you are kind of guiding by pulling with this vacuum to get the baby out.
So it's basically through
like a suction cup. Yeah.
And this is literally during normal labor. It's happening at that point. It's not
we're past the labor point. We're talking about pushing.
Right. So when the woman is actually about to deliver,
yes,
but then for some reason it's more difficult.
Exactly.
Okay. And at that point you can use that. And
yes.
And so does it create a vacuum, or you're literally like putting it on the baby?
No, it literally goes onto the baby's head.
Wow.
Creates a suction cup in order to, as the mom is pushing, you are also guiding the baby's head out.
With the head.
You're pulling.
You're pulling the head.
Yeah, exactly.
And
there are many different reasons why we would have to do something like this, which we'll get there, I guess.
Right. Okay.
Because another way of delivering a baby would be something called forceps, which, especially like when I think of like back in my mom's day or something, forceps were very commonly used. Forceps are a device that goes along the walls of the vagina and kind of cups the baby's head, and then can do a couple of different things depending on the forceps that you use.
So the forceps like tongues?
It looks like tongues.
Okay.
I know. It looks like tongues. And the forceps would go in, cup around the baby's head, and then again, you can guide the baby's head out as the mother is pushing, or you may need to rotate the head. So sometimes forceps were used in order to actually rotate the baby's head to make it easier for the baby to come out. And we still use these today, whether it's a vacuum or forceps. I would say that forceps may be less so, or it depends on what part of the country you're in, providers being more comfortable using one modality versus the other. In my own hands, per se, I would say that I am way more comfortable to use a vacuum than I would be to use forceps. I would not use forceps just because I haven't done them in so long. In my area of where I was trained, it was just less commonly used.
So does it happen often that you need to use these two like devices?
I would say it's common enough that it's good for people to know that they exist. And it's what we call an operative delivery.
So what does the word operative mean?
Meaning that we have to use some type of device in order to effect the delivery vaginally.
So the woman is still pushing. So
yes.
So those devices, they're not doing all the work. It's really to help it.
Yes.
To help the whole process.
Exactly.
And usually you would first try to see if the woman can push by herself.
Yeah, for sure. Most of the time, the woman is pushing by herself, but then something changes in the moment of her pushing, whether it's because she becomes exhausted or there's a change that's a more dramatic change in maybe the baby's heart rate, that it seems that it would be faster to help her with the delivery vaginally than it would be to, let's say, totally change course and go for a cesarean delivery.
And when you use these devices, because literally the vacuum is you're using it to pull the baby's head towards,
Yep.
does that harm the baby?
So in any way you do this, whether it's a vacuum or forceps, there are all risks involved with this. And so the point of when it comes to doing some form of operative delivery, it must be that those risks outweigh the risk of continuing to push, for example, without effecting delivery immediately. It has to be a very calculated decision to do an operative delivery, because even in a regular delivery where you have nothing, you do nothing, the woman pushes out the baby herself, there's still risks involved. And it really is a balancing act of what are we willing to accept?
So it's a case by case and moment by moment.
Absolutely. The one thing I wish more people could understand is how much things can change in an instant when it comes to having a baby. It's a process that can really change quite dramatically from one moment to the next. And yes, I would say, more than 85% of the time, things are happening great.
Like just like a
Like
normal,
the way that
natural
it's supposed to
vaginal-
be,
Right.
the way that it's supposed to be, especially if we allow it. But even under those circumstances, we have to think about the preparation, that what if something can go wrong or things change in a way that makes us have to intervene.
So it's really more, it's not like, okay, it's taking forever, I'm going to use this device. It's really like, okay, we have to do something else now, because either now something might go awry.
When I say awry, we are often a delivery, having a baby, your provider is managing two people. We are managing the mother and the baby. We're managing both lives. And to that end, what if the mother really is truly too exhausted to push a baby, and then that baby then is just kind of stuck in the birth canal and she's not able to push that baby through? Other things start to happen. The area around the baby in terms of the vagina then become more swollen, then making things again more harder for her to deliver.
Even more.
Exactly. That may be one thing. Also, by having the baby there for, X amount of time, I'm not going to give any specific time frame per se, but the baby then starts to respond to that because it's just stuck. And the baby then can respond to that in a way that's adverse, with the baby's heart rate changing and things like that. So it's like you have to kind of follow the signs.
So you're thinking, you have like 10, 15 things going on in your brain. Like, this is what's happening with the mother, this is what's happening with the baby, this is what's happening with the vagina, to try to get to the right thing to do.
The right balance
or
of
not
how
to do at this point.
Right, to get to that right balance. And like I said, the majority of women are able to have nice, like vaginal deliveries without interventions. They can push their babies out. They can, women are exceptional. And the woman's pelvis is an exceptional, part of anatomy in terms of what it is capable of, which is what's so fascinating, honestly. But at the same time, I think the beauty of being what I consider myself as a birth attendant is someone who can affect change when it needs to happen right away to make sure that the baby is safe and the mother is safe.
What do you mean by birth attendant?
Well, I don't want to take on the role only and say that all deliveries have to be done by doctors.
Oh, okay.
Right? It could be a midwife, who is delivering the baby. It could be a nurse practitioner who's delivering a baby. It could be a PA who's delivering a baby. Like, there's so many different healthcare providers when it comes to vaginal deliveries. And I think it's important to also pay homage to those who've been doing this for years and years in the villages and in the bush. And you know what I'm saying? Like, even there, they are people who have been trained by their, ancestors, etc., who have really taught how to do this. And I don't take anything away from that.
So we talked about vaginal delivery, and then when there's potential complications, then you make it more operative.
Yes.
I'm learning.
Good.
Which is through the vacuum and the
forceps.
Yeah, I'm not there yet. Forceps. So in what situation then there's a shift that could happen towards a C-section?
So C-sections can be under so many different circumstances. I would say that perhaps, especially in this country and across the world, maybe even, the number one reason that a woman may have a C-section is because she's had a previous C-section. And so that's why one of the things that is so important is that we try to prevent even the first C-section in the first place.
So let's describe what a C-section is.
A C-section is a operative delivery. It's a form of an operative delivery. It's where the baby, though, is delivered through the abdomen. So we have to cut the layers of the abdomen to get to the uterus, and then we cut the uterus in order to get to the baby.
And it's usually like below the belly button?
Usually definitely below the belly button. In some places where what's called a vertical incision is still the primary way that they do C-sections. Certainly in the olden days, this was a very common way in which C-sections were done.
So when you mean vertical,
I mean going up and down. So like, let's say from the belly button down in a up and down way to just above the pubic symphysis, or where we say the top of the vulva would be, or the mons pubis, or
where our hair,
I'm thinking where hair starts. Yes,
okay,
I know. I'm trying not to talk doctor speak. I'm sorry. Yes. More commonly now, we do the quote unquote bikini line cut, or in doctor speak would be a low flap transverse incision.
Which is horizontal.
Fan and steel.
Which is horizontal.
Which is a horizontal cut.
And that is
very low,
right above where the pubic hair starts.
Right around in that area. Yes.
Okay. And so do you still do both types of incisions, or
it really depends. Okay. Again, there's so many factors to why a person may have one versus the other. But I would say the most common way is to have the bikini cut, the horizontal cut, the fan and steel cut. Those are all equivalent in some ways. But just so people can kind of understand, if you've ever heard any of those terms, a vertical cut is typically done because of either the baby's position, or a woman has had a previous vertical cut, and we like to typically go through same scar, or she has some other anatomical reason why it's better to do a vertical incision in order to have more access for delivery. I would say common reasons may include things like big fibroids, for example, may necessitate having a type of incision like the vertical incision.
And so when you do a cesarean, usually is it full anesthesia, local anesthesia?
That's a great question, Touseef Mirza.
Thank you.
When we do cesarean sections, it's usually under a form of local anesthesia called a spinal or an epidural, which is anesthesia where the mother is still awake. And what it does is basically numbs the mother from the belly button down. And so in order to be able to operate without her feeling, from the basically like the waist down, from the belly button down.
So she's conscious.
So she's conscious.
Yeah.
And in a C-section or a cesarean section, you can feel pulling, tugging, you'll feel touch. Sometimes you don't feel any of that, but those are very common to feel. But in a C-section, you really shouldn't feel sharp, but you may feel pressure. And you may feel people touching you, but you don't feel sharp. So the knife, for example, or, other instruments that we use.
How long does it take for it to have effect?
So it's very quick. Most of the time when we use a spinal anesthesia, within 5 or 10 minutes. It's pretty effective.
So when you say spinal, is that something that you're injecting?
You inject an anesthetic. It's the anesthesia that goes into the back. A lot of people are very afraid of, just because most people are afraid of needles in the first place. And the concept of getting a needle in your back gives people even more heebie-jeebies.
And that's lower back.
And it's in your lower back. That is correct. And either a spinal anesthesia or epidural anesthesia both include anesthesia going locally through the back. And it's which space the medication goes through, whether it's before the spinal cord or in the column where the spinal cord is, of where the medication actually goes through. And that's getting very technical, but I guess the best way to understand it is that it's medicine that goes through the back where the nerves pass through, the pain fibers. And it's to help anesthetize or numb those pain nerves from I would say about belly button down.
Okay.
Yeah.
So that's pretty wild to have surgery, but you're still
awake.
Still awake.
Yeah.
And they're still pretty, like they're
completely lucid. Yeah,
they're able
you're
to
awake,
talk and everything.
Yeah, I talk to my patients. Do you like the music? Would you like me to change it? And then the thing is that oftentimes when you're doing a C-section, it's pretty quick from the time you make your incision to the time that the baby's actually delivered. And so oftentimes it's just a few minutes and you get to kind of hear the baby cry, and you can, in some instances, I can show the mom the baby right then and there.
That's amazing.
Yeah. Yeah. And there's so many different reasons why a woman may need a C-section. Probably one of the more common reasons is just because if she's had a previous C-section. And then outside of that, it's perhaps baby's position. So another pretty common reason is something called the breech, or when the baby is sitting down in the pelvis or in the uterus and versus having the head being the presenting part, or the head being down.
That's the first thing that comes out the vagina.
Exactly. I would say for the most part that a breech delivery is more uncommon now. It used to be that we did breech deliveries a lot more commonly, but in a country that has so much litigation and there's a lot more, it does require a lot of skill. And it's a skill set I feel like has been just getting lost more and more and more over the years, because of the fact of going to a C-section is certainly considered a safer option when it comes to a breech delivery. And then there are other reasons in terms of a woman who actually we expect to have a vaginal delivery. This happens very often. We expect a vaginal delivery. We're in the middle of the delivering process. And for whatever reason, she either doesn't dilate all the way. You have to get to what we call fully dilated to have a vaginal birth. And for whatever reason, that just stops. The dilation stops.
Meaning the opening stops?
Opening of the cervix that has to happen in order for the baby to be able to come out completely just stops. And even with help, even with perhaps augmenting labor or giving her medications to continue to have contractions, still doesn't allow her to continue to open. And so if she's not opening, then, after several hours of this, where the woman is considered in labor and we're doing all the things to try to get her to deliver and it's not happening, then we have to move on to a C-section. That's one potential. Another thing could be that while she's in labor, something changes with the baby that causes the baby that we are watching while we're monitoring the baby that makes us feel that the baby may be in some kind of distress. And then that may be another reason why a woman may need a C-section. And under those circumstances, sometimes it's emergent or we have to do it right away in order to safely have a baby.
So as you're talking, when we talk about a C-section, are you trying at all cost not for the woman to go through a C-section?
I would say yes. I know so here's what I'm going to say. I'm going to speak from my own personal experience. This is what the Dr. Sophia ObGyn podcast is about. It's about talking about my own personal experience. I'm not here to give medical advice or to talk about what other people do or why they do it. In my hands, the reality is that I love a vaginal birth. It's such a great experience. It's definitely one of the things that drew me to the profession, right? But moreover, I recognize and understand how important it is to really prevent that very first C-section.
And why is that?
Because the more C-sections you have, that comes along with its own risks. And it also increases the chance of having another C-section.
So when you say increases risk, what does a C-section increase risk in?
I think one of the things that people may not understand or not even recognize is the fact that a C-section is truly major abdominal surgery. And so in that, it comes with the risks of bleeding, infection, and further down the line, there's the risks of something called a small bowel obstruction. This is where scar tissue that may form and then kind of rubber bands around your bowels and they get twisted. Like, it's just, don't get me wrong, C-sections are necessary. I do them all the time. And they really help women who are not able to have vaginal births still have babies. Let's be clear. We need to be able to do C-sections. But I also think that sometimes we rush too much to do a C-section in a woman who may be able to do a vaginal birth. And we have to be clear on the indications and the reasons why we end up doing C-sections. Sometimes when we think about the mother and the baby or the fetus, the reality is that sometimes the fetus or the passenger is just too big for the mother.
Like a big baby.
Like a big baby, a basin that that baby has to go through, you know? So there are so many reasons why we have to do C-sections. And thank God they exist so that way we can still have healthy mommy and healthy baby. But at the same time, I think women also have to be very supported in trying to have vaginal births.
So I think one point that you brought up that's really important, because we say C-section and because there's a lot of people that have C-sections, I think you're right. We have to recognize it is an operation. And like with any operation, it's a big deal. Like anytime you open the body, there are so many risks involved. And that's one of those types of operations.
100%. Absolutely. And I don't want to take anything away from, let's say, a vaginal birth, right? So vaginal birth also holds its own risks. I mean, other kinds of forms of birth trauma to the pelvic floor, to the vagina. It can lead to higher chances of women having things such as stress urinary incontinence. I mean, listen, the thing is, things can happen on either side. But I would say that a vaginal delivery that goes smoothly with especially a very normal sized baby and a healthy mom, you know, the recovery of after a vaginal delivery is rather quick in the sense of being able to care for yourself, being able to care for your baby after a vaginal delivery. Sometimes that process is a little bit longer if you've had a C-section in terms of caring for yourself, in terms of caring for your baby. And it makes sense. A major abdominal surgery requires more pain medication, for example, may require more rest, which you need on both sides, whether you've had a vaginal birth or a C-section delivery. But the recovery from those two things are a bit different. And the bonding that needs to happen between the mom and the baby is a little bit different if you've had a vaginal delivery versus a C-section. Because after a C-section delivery, it's not that easy to do things like immediate skin to skin. You're still operating literally, you know? And so oftentimes...
is it face to face?
Face to face?
Like bring the baby close to the mama's face?
We do that.
Okay.
We do that. But even that just is for like moments of time, as opposed to after a vaginal birth where the mother may have a lot more time with the baby doing skin to skin. There's a lot that goes into delivery. And I think that's partly why it was so important that we just talk about it in a very candid kind of way, because there's no one size fits all. There's no right way. There's no this way or that way. It's just a conversation that I think it's important to have. And many people, like I said, we just don't know. We just don't know the terms, the terminology, a C-section, a delivery, a vaginal delivery, a vacuum delivery. And then even let's color it with another thing, something called a VBAC, which is a vaginal birth after C-section. So someone who's had a previous C-section and then has the attempt of having a vaginal birth and actually successfully has that vaginal birth is called a person who's had a VBAC. But before they actually do that, we call it a trial. Okay. And all of those, I mean, literally women go through the gamut. They go through so many different ways of having a birth. And I just think it's important that we feel comfortable talking about it with our providers, having honest conversations, how we feel about it. I think most women really don't want to have a C-section. And on the flip side, there's a subset of women who are like, I want to protect my vagina at all costs. Give me that C-section.
That and do women come to you, and also especially if it's their first child, going, I'm just so scared.
Yes.
Can I please have a C-section?
Yes.
I don't want to go through that.
100%. And guess what? That is their right.
They can? They can ask for a C-section.
That is their right. I will say that when I get that woman who comes in and says, I'm just too scared, I do try to talk to them and really find out where the fear lies and give them a little bit more like context as to what a vaginal delivery may entail for them specifically. And it matters. Are they having other complications in the pregnancy? Are they having, other reasons to have those concerns and fears? And so for me, I probably would say that I typically, even if a woman does come to me and says she just wants to have a C-section, just full stop, I make it a much bigger conversation for sure.
So as an OBGYN, your default is to try to have a vaginal delivery.
Yes.
That being said, if a patient comes and starts the conversation with, I'm not having that, like I want something else, then that's a place where you can have a conversation. But you're not going to yourself propose, do you want a C-section or vaginal birth?
No, that's not going to be how I start the conversation.
No.
It's like, oh, well, since you're pregnant now and, would you rather have a vaginal birth or would you rather have a C-section? I'm going to be honest with you and say no. No, that's not how I start a conversation. The default is that we're going to try to have a vaginal birth, a C-section, if it becomes necessary. And then that few subset of women who do elect to have what we call the elective primary C-section or that first C-section, I just have to be honest that that's just not the first place that I go. We have a lot of dialogue around it. And if ultimately we end up there, then we do. Because like I said, the women have autonomy.
When you say, that's how you function, you're also basically saying that different providers view this or have different approaches to that. Other providers are more open to, what do you want type of deal.
Oh, yeah.
Okay.
For sure. For sure. There are definitely other providers who are like, okay, you want a C-section? No problem. Let's do it. And there's no further conversation about it. And again, I recognize it's because women definitely have autonomy, definitely can say, hey, I'm either too afraid or I just don't want to. I just want to have a C-section. And yeah, they're going to find providers who are going to oblige. But there are certain circumstances where they're not wrong. A woman who perhaps is 42, and I'm just throwing out an age here, guys. This is not a end all be all. Let's just say I have a 42-year-old woman. She's had 3 previous miscarriages. She's gone through IVF to have this particular baby. She's gone through the pregnancy with all kinds of other, small issues, what have you, and says, I'm not going to try to do this again. I am really scared and I just want to have a C-section. that woman, I would say, you know what? You're probably right. Let's just go ahead and have a C-section.
Because she's
because she's already at high risk for other things, and whether it's, preeclampsia, gestational diabetes, etc. Just, the mere fact of her having an IVF pregnancy, her saying that this is it. I don't expect to have any more children. This was already hard for me. It is a conversation.
There's so many variables.
All the time.
There's so many variables to consider that can change the course of how you want to deliver a baby. Like, that's what I'm really getting out of this conversation.
Yes.
That there's just so much, like your brain, when you're in that situation, I don't know what's going on, but it fires,
bing, 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 bing. What are we doing? What are we doing?
Everywhere.
Yeah.
And also before, like, you're considering all these different things. So it can be quite complicated. It's not just, do we do this or do we do that?
Yeah. I mean, it feels like it should just be very easy. And listen, part of the reason why I love OBGYN is because I consider it happy medicine. I really do. Delivering a baby, being in that delivery room, whether that patient does have a vaginal birth or a cesarean birth, vaginal births, honestly, my absolute favorite, it's really a place of sheer joy. Yes, a lot of variables can happen. A lot of things can happen. But at the end of the day, a birth is a birth, and it's a joyous thing. And I feel like whether that birth, however way we execute it, is a birth. And ultimately,
you're meaning basically just by having a C-section doesn't make it less of a birth.
Oh, absolutely. That's what you mean? Not. Yeah, absolutely not. Having a C-section does not make it any less of a birth, or your birth story, your birth journey, your birth process. It doesn't take anything away from it. It's still pretty amazing. Mm-hmm. So I just want to be able to help women have that, not just understanding, but I do want women to have the birth that they really want. Women, birthing persons, this was really for you. And especially to my Black birthing persons, may your birth story and pregnancy and care be handled with joy always all around you. As we say here on the Dr. Sophia ObGyn podcast, always embrace your body, embrace yourself, embrace your birth, no matter how it happens. It's beautiful. Thank you for listening. Bye for now.
Bye.
This is general medical information based on my professional opinion and experience. For specific medical advice, please refer to your physician. Until next time, embrace your body, embrace yourself.